Okay, so hi everybody. It is 1:30. We're getting ready to start. As people continue to filter in, we're just going to make introductions here to this congressional briefing. This is in fact our 23rd congressional briefing. This one is on science-driven approaches to reducing inequities through public health policy. And it's sponsored by the National Prevention Science Coalition to Improve Lives. My name is Dr. Diana Fishbein. I'm in the Frank Porter Graham Child Development Institute at the University of North Carolina in Chapel Hill. I'm also at a part-time position at Penn State University. So we appreciate your interest in this very important topic, and we're very excited to bring you some national experts to talk about deploying prevention strategies to improve racial equity in our country, particularly in issue areas such as education and health. Research and experience provide guidance about what works to reduce racial equities and improve health outcomes for all Americans. So despite the existence of strategies shown to reduce inequities and foster equitable practices, translating that knowledge into effective policies has really lagged behind the science. Speakers in this briefing will present evidence-based prevention policies that reduce the conditions that perpetrate the inequities and strengthen factors that protect against them. So the National Prevention Science Coalition to Improve Lives is a large professional organization made up of scientists from across the disciplinary spectrum, as well as educators and clinicians and national and community organizations, practitioners, and others. They're all dedicated to translating the scientific knowledge into effective policies, systems, and practices. We focus on evidence-based strategies to prevent the development of behavioral and mental health issues that are largely the result of detrimental social conditions. So we work with Congress as well as state and local agencies to inform public health policies that ultimately will benefit children, families, and communities. Now, just a couple of housekeeping items before I turn it over. Please do feel free to submit your inputs and introduce yourselves into the chat as you like. We won't be able to monitor the chat with so many people in this briefing. Scrolls by really quickly. So we won't be able to monitor it. Please do not submit your questions to the chat, but feel free to introduce yourself and add links and resources to the chat. And we will develop a compendium of resources later after the briefing for all to view on our website. If you have questions for the speakers, please do submit them to the Q&A. And as I said, not to the chat. And the speakers will address as many of them as possible towards the end of the briefing. Once the briefing is over, it usually takes a week or two, we'll have all the accompanying resources and videos and slides on our website to be shared with you. So please check often. Now, this virtual platform enables many more participants than briefings in the past because we're not restricted to the limits of seating in a room, but we do appreciate your patience in case we have any technical difficulties. I don't anticipate that we will. So let me now introduce you to the moderator, Dr. Stephanie Ramos. She's a behavioral health researcher at RTI International here in North Carolina. Her research explores how interactions with the American healthcare, education, and legal systems impact physical and mental well-being in communities with low income and/or racial minority populations, with a focus on violence prevention and mental health promotion. She is currently leading evaluations on a number of studies, including a district-wide school threat assessment and response system in rural North Carolina, as well as a citywide initiative to reduce violent crime and adverse childhood experiences in the state of Wisconsin. So Stephanie, I'm going to hand it over to you.
Thank you so much. Hello, everyone, and thank you for joining us today. To get us started, Congresswoman Deborah Ross has kindly agreed to speak on today's topic. So we will play that video for you now.
Hello, I'm Congresswoman Deborah Ross from the 2nd Congressional District in North Carolina, representing part of the Research Triangle. I am honored to welcome you to the beginning of this policy briefing for NPSC. You are using your knowledge and your connections and your data to bring equity to healthcare. This is so important. For too long, we haven't had the information that we need to serve all of our people. As a matter of fact, I was with the governor this week, and he talked about how important it was that we collected even more data than the federal government required about people during the COVID pandemic. It let us know about pre-existing conditions, how to reach underserved communities. Data makes the difference. If you don't know what the problem is, it is hard to solve it. I am so glad that you are working with practitioners, with researchers, and that you're coming together to share your information for the good of all of our people. Thank you for what you're doing. I cannot wait to hear what your research and your exchange of ideas reveals. I am so honored to serve this area.
We have 3 fabulous speakers with us today, and I'll introduce each one of them individually before their presentation. But before we begin, we wanted to share the definition of equity that we used in preparation for this briefing, seen in the next slide. So equity is when everyone has a fair and just opportunity to attain the highest level of well-being. Achieving this requires focused and ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to full participation in society, and eliminate preventable disparities. So now it's my pleasure to introduce our first speaker, Dr. Rachel Shelton. Dr. Shelton is an associate professor of socio-medical sciences at the Mailman School of Public Health at Columbia University. She's also the Deputy Chair for Faculty Development and Research Strategy and the co-director of the Community Engagement Core Resource at the Irving Institute for Clinical and Translational Research. Dr. Shelton's work includes advancing the implementation and sustainability of evidence-based interventions in community and clinical settings to address health inequities. And with that, I will hand it over.
Thank you so much. Next slide, please. Wonderful. So I'm so honored to be here today as part of this panel, and I'm really going to focus on how we can apply implementation science to advance equity through a focus on policy and prevention. Next. I think it's important to recognize that health inequities are not new. They are longstanding and they are persistent. But there has been a shift in terms of a greater focus and recognition of advancing health equity, where everyone, again, has this fair and just opportunity to be as healthy as possible, with recognition that there are historical factors and injustices that have impacted health, and that there are a lot of structural causes that have shaped this, related to, again, poverty, discrimination, lack of access to education, safe neighborhoods, and housing. And because of this historical context, it's critical that we invest in resources that might look different in terms of who has access and opportunities at different levels to address these inequities. Often these health inequities are intergenerational. They're passed across families over time. They intersect and are reinforced across multiple sectors, not just health, but again, education, housing, neighborhoods. So prevention and investment early is critical. Next. We know that policy is a huge lever for health and health equity. Policies are critical. We've seen the numerous ways in which they've advanced public health impact, whether it's seatbelt laws, tobacco laws, or access to cancer screening. But it's really important to recognize that policies are not one size fits all. Policies can shape, reinforce, reduce, or even worsen health inequities. And health inequities can really exist at multiple levels. This may relate to geographic inequities or inequities across the types of settings in which we receive care, like safety net settings as one example, or they may relate to characteristics of our population and social factors like race, ethnicity, income, insurance, or language. And all of these factors often intersect as well at multiple levels. Next. Policies are so powerful because they really provide the context by which structural and social factors influence health. They shape the social determinants of health. So again, not just the quality and access to health care and health quality, but again, our neighborhoods, our housing, our community context, our exposure to violence or risks, our education and income and economic opportunities. And again, the root causes of inequities are systemic, relating to factors like structural racism. And because of that, it is critical that we are thinking about policies and solutions in each of these sectors to address these root causes and really promote solutions in all of these areas. Next. Too often, we have really relied on this assumption that if we just build the right evidence base, the right science, if we just pass that one policy, if we build it, they will come. But we know it is much more complex than that. And we really need to think about what are the supports and resources and investments we are making to ensure that translation to impact health equitably. Next. So there's been a very well-documented gap between research and practice. And again, we know that policy can impede or accelerate that gap. But it's important to recognize that having an evidence-based guideline or policy alone does not lead to or ensure widespread or equitable adoption or impact of that policy for all groups. Again, evidence is just one piece of information, but we're working in complex social and political contexts, and the needs and resources in the settings and populations we're trying to reach are variable. Next. Next. You might have to hit it a couple times. And one more time. Thank you. So, of course, not all policies, as we know, have equitable reach and impact. And there's lots of reasons for this. First of all, we've often taken a one-size-fits-all approach to our evidence base and our policies, and there might be a mismatch that really matters. So our policies may not focus on equity or necessarily reflect the priorities, experiences, cultural values of a lot of historically underserved communities. Our settings, our communities, our jurisdictions where policies are delivered are not necessarily comparable. They have varying levels of resources, infrastructure, competing demands, staff shortages that can really exacerbate inequities at multiple levels. Our policy implementation complex is dynamic and complex. We have changing priorities over time and also uneven delivery, regulation, monitoring, and enforcement that can unevenly impact different populations and settings. And of course, there's the potential for negative unintended consequences. Our policies are not one size fits all in terms of who they benefit. And some may actually compound inequities. There may be financial costs or health issues that are exacerbated, or mistrust of communities that are exacerbated through policies. So in some cases, we may need to adapt our policies over time to address equity. And in some cases, there may be policies that are harmful that we may not need to actually remove to promote equity. Next. So there's multiple gaps in this whole implementation process. So even if we have a policy that is, or a program that's 100% effective, it's only as good as whether and how it's adopted widely across a range of settings that local stakeholders and staff choose to deliver. It can be equitably and consistently delivered with quality, that the recipients are able to receive it, and it can be sustained over time. Next. So it's important when we think about policy, it's not just about passing the policy, it's really thinking about where and when these multiple gaps in delivery across the policy cascade can occur. And at each of these phases, whether it's adoption to the settings, implementation, and the extent of delivery, the reach to the intended recipients and settings, its impact, its effectiveness, and its continued delivery. We could think about at each of these levels where and when inequities might arise that exacerbate health. But we could also think about these as opportunities to promote equity if we're accountable and tracking what's happening at each of these phases. Next. So how can we address these key gaps, and how can we actually accelerate and use science to promote the equitable adoption and impact of evidence-based policies to promote equity? Next. So there's been a huge development in an area of science that I've been involved in called dissemination and implementation science in the past 20 years that has really evolved to help accelerate and address this research to practice gap and really think about how can we translate evidence into policy to have impact equitably. So it's all about not just the how, what's the program or what's the policy, but what are the methods, strategies, frameworks, and tools that we can use to actively facilitate and support the routine adoption, use, and delivery of evidence-based programs and policies for all settings and populations. Next. Go ahead and click a couple, that'd be great. So one more. So what would this look like in the context of applying implementation science to promote equity for policy? So one focus could be really thinking about how can we enact policies that are aligned with evidence that promotes equity? How can we think about accelerating not just the narrow adoption, but the widespread adoption and dissemination of equity-focused policies and programs? And how can we optimize and be really accountable in tracking and enhancing the equitable rollout and reach of policies to really maximize those health benefits? Next. So these are my recommendations for what we can do to do this more intentionally. One is we can't think about health equity as a tag on at the end of the process. We really have to start with that focus and framing and reflect on our evidence base for policy. And starting with a focus on equity and reflect on what are we counting as evidence and for whom is a policy evidence-based. This requires that we really prioritize policies addressing social determinants of health, and that we're not just working in health settings, but again, that we are really focusing on multi-sector settings that we know impact health. We must also be partnering with historically marginalized groups and community organizations to understand context and their barriers, their perceived barriers and real barriers to policy implementation in their communities. So again, thinking about partnerships in educational settings, faith-based organizations, and across transportation and different social service organizations is critical. Next. It's also really critical that we are engaging early and often with community partners and stakeholders across multiple sectors to inform and plan for equitable policy uptake and delivery. And if we think about all these different stakeholders at all these levels, we really have to reflect on who is and is not represented, who's not at the table, and think about reach and representation of settings and populations to enhance equity. We know that stakeholder engagement is critical to enhance the fit, the relevance, feasibility, acceptability, and appropriateness of policies. We have to provide opportunities for historically disadvantaged communities and settings to partner and identify and really amplify their perceptions of what the relevant solutions are to build trust and trustworthiness, and to really ground policy and policy rollout with input from these end users and community partners. We know this is essential to plan for and actually facilitate equitable uptake. Next. One more, thank you. So one example of this, so in my work over the past 12 years, I have partnered with a group of African-American cancer survivors from the National Witness Project. This was a community-led program where peer leaders really provide education and support in community settings to support cancer screening. And through this work, we have learned time and time again of how important alignment with policy at all levels is to support the continued delivery and sustainability of this program, and how partnerships are critical to address some of those resources that are not available in a lot of these community settings. But we've also learned how important the nature of the evidence base is. We often just assume we can roll out these new guidelines in cancer screening, this new policy, and everyone will, be running to adopt it. But we really have to contextualize that evidence. For cancer screening, a lot of the trials that have informed screening guidelines have not reflected or represented the experiences of African-American women who experience higher rates of cancer mortality and more aggressive tumors at younger ages. And so a lot of times there's distrust of guidelines that do not reflect the lived experiences of populations experiencing inequities. And this may actually reinforce mistrust and wariness of our evidence and policies. And this will result in low uptake in settings that would benefit from them the most. So again, thinking about engagement, equity, and representation from the start and informing our policies and guidelines. Next. We also have to think about how can we advance understanding of how to facilitate widespread and equitable dissemination. We have to really understand the priorities and motivations of those who we're trying to facilitate adoption among. How can we tailor and communicate evidence and our policies to a range of systems and contexts that have variable resources and interests to influence adoption and use? We have to understand to them, who are those key stakeholders? What do they value? And what factors might influence the speed and extent of adoption? Who are those trusted messengers? So thinking about things like cost, value, advantage, simplicity, acceptability. All of these are really important in terms of how we shape that messaging. And there's been some great work thinking about really tailoring and planning those dissemination strategies to accelerate policy adoption. Next. We also really have to think about, again, not just that we pass the policy, but that we're being explicit in tracking equitable policy impact and delivery over time. So this requires attention to monitoring and tracking this, and really thinking about the possibility of uneven implementation for different settings and populations. We have to be really explicit in considering these gaps and inequities as well in enforcement, regulation, and monitoring, and identifying, if we think about all these different contextual levels at which this is happening, at all these different levels, when and where are those inequities arising, and how can we address them? And it's important to understand the why. We can only address them if we understand some of the contextual barriers and facilitators to policy implementation at each of those levels. Next. So again, if we think about our cascade, our policy implementation cascade, really being accountable and tracking when and where the gaps arise and how that might exacerbate or reduce inequities. So if we're thinking about adoption, which settings are able to participate or adopt or not? If we're thinking about implementation, where is there uneven implementation or enforcement or regulation? Which populations are reached or not? And is the policy effective? Is it having the intended benefits in terms of the health outcomes or access to health care or improving social determinants of health? And how is it maintained or not over time? And we can think about this as not a one-time process. This might be an iterative process over time to do this tracking. And over time, it may mean that some policies, again, have harmful unintended consequences and may actually need to be adapted or removed. Next. So here are some examples of some equity-focused policy implementation metrics. Again, asking, are all populations equitably reached by the policy? Who is not and why? Are all the health benefits and burdens equally distributed? Are all settings able to adopt? Was the policy equitably implemented to the full extent? And then maintenance, how is it maintained and continue to have impact over time? So again, these are indicators we can bring to our policy implementation efforts. Next. Finally, it's really critical that we're building an evidence base for policy relevant strategies that can actually support, give resources to invest in the implementation of equity focused policies and programs. So at each of these levels, based on where we're seeing these gaps and barriers, this might look different, but this could include access to new funding, altering patient or consumer fees, changing some of the accreditation or licensure requirements, changing liability laws, building organizational readiness, planning for reimbursement, mandating change. So again, thinking about all these policy relevant strategies that we can refine, test, and learn from to actively promote equity through policies and programs. Next. And again, as we go back to our cascade, this is where that accountability and tracking when and where the inequities arise at each level are so critical, because they can really point us to where we need to invest to address some of these gaps. So again, if we're seeing inequities related to adoption, we may need to align our policy incentives with accreditation. If we're seeing them related to implementation, we may need to make implementation simple, low cost, and burden-free, and provide support or financing for policy delivery. So again, at each of these levels, we can think about the strategies needed to address these inequities. Next. So I'll just close by saying, no matter the sector we are working in, whether it's schools, education, work sites, criminal justice, implementation science tools are a really critical lever for us to accelerate and track progress towards health equity and equitable impact of prevention policies and programs at scales. We know that health inequities are complex, they are structural, they are interrelated. So our partnerships, our solutions, and our policies must also be multi-level, multi-sector if we want to see effective and sustainable change. And I think we all have the opportunity to really consider and reflect how we can make equity more foundational to our work and really invest in equity-focused partnerships, policies, and programs that bring resources to communities that experience historical and ongoing structural barriers to health. So I'm going to pass it on to the next speaker, Dr. Aruka. Thank you so much.
Thank you, Dr. Shelton. Our next speaker is Dr. Ioma Aruka, who is a research professor in the Department of Public Policy and a fellow at the Frank Porter Graham Child Development Institute at UNC at Chapel Hill. She is also the founding director of the Equity Research Action Coalition at FPG. Dr. Aruka's research shows how evidence-informed policies, systems, and practices in early education can support the optimal development and experiences of children from low-income and ethnic minority households. Dr. Aruka?
Thank you so much. And again, thank you to Dr. Fishmine, thank you to Dr. Ramos and the NPSC, and of course, as well as to my co-panelists as well. So glad to be here with you all. Again, Ioma Aruka, and my pronouns are she, her, hers. And I'm just going to take a few minutes just to talk to you. Next slide, please. Just to talk with you really about protecting, promoting, and preserving the health, wealth, and educational excellence for Black families and their babies. And really, I would say that for me, just to give you a little bit of a sense, that I do a lot of work in the early childhood, sort of prenatal through age 8 space. With a focus primarily on minoritized populations, especially Black children, Latino children, children living in poverty, and children with disabilities. But again, a lot of my center is really focusing on Black communities. Again, the historical legacy of racism is really part of my own work and research. And so before I really move to the next slide, I want to sort of at least let you know kind of my large, so like the things to remember, if nothing else. One is that early experiences are really important if we think about issues of public health and just healthy well-being and wellness. so thinking about early experiences are really important for children, and it really impacts them over the life course. We also know that early adversities can change the time and of critical periods of brain development. But we also know that healthy development for children begins preconceptually, right? So in the preconception period. So how do we make sure we think about health, not when children are here, and obviously when they're youth and adolescents and adults, but really before they get here. But we also know that just the important power of relationships. Again, for all of us, as sort of probably all of us who are here are grown, right, adults, but also for children, that really matters to really buffer children against stressors and adversities in many ways. And so, how do we create nurturing and affirmative spaces and relationships? But I also want to sort of, I think, especially to Dr. Shelton's talk, right, that we have to also think about the influence and access to basic resources, right? So you can't talk about public health and health issues writ large without thinking about really the impact of access to basic resources, food, shelter, healthcare, childcare. They're really powerful levers, and they limit chronic stress. And this is particularly something that's critical, particularly for those from racially and economically deprived and disadvantaged communities. And we all have to agree, if nothing else, that both institutional racism, right, also called structural racism, and interpersonal experience of discrimination, they can influence the health and well-being of children and adults in many, many complex ways. And so we have to recognize that the public health policy has to think about all of these issues, especially when thinking about young children, but also young children and their families. And so now what I'm going to do is just give you a smattering of some data, and then I'm going to then really sort of point out some big policies that we can think through if we're trying to sort of think about issues around reducing inequities through public health policies. So next slide, please. So so for those of you who are here, you probably have seen many data really about the racial disparities in low birth weight, in preterm and maternal mortality. And what this does is just show it to you, right? So the light blue color are Black families, the darker blue are Hispanic Latino families, and then our red bars are the white families. So in essence, we just see disproportionately that Black babies are likely to be born low birth weight and also preterm compared to other groups. And we can also actually include Native children, Native American children in the slide, similar to Black families and Black babies, I should say. And we also know that both Black birthing people as well as Native birthing people are likely to also die either during or after, within the first year of childbirth. So these racial disparities are really pernicious and have been present for a long time. And we do know that structural and interpersonal racism, which I'll talk a little bit about in a second, is linked to really Black and Native children likely to be born low birth weight and also preterm, and also linked to Black birthing people and mothers likely to die during pregnancy, delivery, or postpartum compared to other groups. Again, we have to recognize it's not just because people didn't go to their prenatal care or didn't eat the right foods, that some of these things are actually impacting the womb as when women before they get pregnant and then when they get pregnant. Next slide, please. We also know that Black families, so from one of our data that we've been collecting with our partners at Stanford University, the Rapid EC study with Dr. Phil Fisher and his team, we have also begun to gather how families with young children are experiencing the pandemic, including their experiences with discrimination. And so in this slide here, you're looking at the data from Black parents of babies. And the dark purple is really the pre-pandemic level, and the lighter purple is basically during the pandemic. And across the board, when we ask Black families, are you experiencing any kind of discrimination, whether it's receiving worse service, being fired or not hired, police mistreatment, denied health care, and or called a slur, we do see across the board that Black families compared to other families are likely to report having all of these experiences. And on top of that, while we saw a reduction in the sort of the beginning throes of the pandemic, and that's pretty much because people were not going outside, right? But what we do see is that a lot of these experiences of discrimination are linked to a host of negative health, economic, and psychosocial outcomes. Next slide, please. And at the same time, from this same exact data source, the Rapid EC study, we also find that about up to 80% of low-income Black families and almost 40% of middle-income Black families report one or more hardships, material hardships, which includes being able to pay for basic needs like food, shelter, childcare, healthcare. And we know this is a higher proportion than, say, other racial groups, right? So this data that I talk about, Rapid EC, has data from Hispanic families, from white families, from Asian families as well, but it's a much more of a larger, I would say, white sample. And so in regardless of, we do see that even for middle income Black families, they're likely to also be economically vulnerable. As a slide here on the left-hand side you see the two panels. On the left-hand side are the Black families. On the right-hand side, the lighter blue colors are the families that are not Black. And what you just see is that there's economic vulnerability with Black families, regardless of their economic standing, whether you're low income or middle income. You have an economic vulnerability that when obviously, as they say, when it rains, it pours for Black communities. We see that with this sort of data in our economic data. Next slide. And the reason for sort of this economic vulnerability, researchers have obviously informed us. Next slide, please. Is that really the issue is really around the wealth gap? And go ahead and click it 1 to 5 times for me, please, Jane. No, go back. No, sorry, go back. Nope. There you go. And then this should be, yeah, there you go. Thank you. Right there. Yes, no, sorry. And so what you see here is that when we look at the reason for the economic vulnerability, we're all sort of positive, is because of the wealth gap. And for those who don't know, wealth is really what you have above and beyond all your debt. And also wealth is what you have across generations. And we know, particularly for Black people and arguably other people of color, particularly Latino people, we do see that for the most part, they've been left out of wealth generation. And so what you can see from this data is that, even the past 30 years, it's been pretty much a flat line primarily for Black families in terms of their wealth. We're talking about $14,000 for Black families in 2019, about $32,000 for Hispanic families, but then that's really much lower compared to white families at about $187,000 median wealth, and for Asian families about $206,000. Again, when you have that level of wealth gap, that also leads to a level of economic vulnerability that really has an impact on your wealth and on your health over time. Next slide, please. And so as I talk about sort of the issue of sort of the wealth gap, we have to sort of really make sure that we're really clear about our language. When we talk about sort of inequalities, there's many reasons for inequalities, right? And for me, I study particularly racially and ethnically minoritized population. And it's really important that we understand also that a lot of the US policies were really shaped to benefit a particular group, right? Primarily white people. That is the legacy of policy and policy making that we still see to today. And so what this visual that we call the Racism, Resilience, Resistant Integrative Study of Childhood Ecosystem, as we call the RISE, a sort of theoretical framework, is that we have to begin to really be clear and operationalize how racism, as one of the big drivers in inequities, how racism actually sort of impacts healthy development, particularly children's development. So if you look at this figure, you see the blue, sort of that blue outer ring, which is really the water, right? The culture of racism, which is the idea that a certain group has really is viewed as the majority. They're viewed as the one that are one that we look up to. And so really we see that in all of our economic, health, and social disparities, the white people compared to other people of color are likely to have better outcomes writ large. And even the ways that we think about Black and white is even baked into our ideology and the way that we function. So if we think about the water, when people say racism is in the water or in the DNA, that's what we mean. But really how it also filters out is through the structural pieces, right? And Dr. Shelton talked a little bit about that. The policies we have around who gets education, the quality of education, the kind of health policies we have, who gets to access healthcare, health insurance, even social protection, who has it, who does not have it, whose protection is actually threatened as we speak here, or even social policies around labor, and market, and even housing, right? So those are structured, and some of those things could be seen in sort of our schooling, our employment, even concentrated poverty and disinvestment in certain communities, mass incarceration, our immigration policies. That means that these things are actually structured in our policies and not because of some whim of somebody, right, who had a bad moment. And then it's interpersonal racism, which we often think about biases. And those are really how, it's like bigotry, how they show up in terms of, we say, we're going to sell you a home because you're white, but not you because you're Black or brown. Or we suspend children because we see a high level of suspension, expulsion of Black children, Native children, and children who don't speak English as their primary language. So we have interpersonal and biases and bigotry sort of across individuals. And then we have things like internalized racism, where you begin to believe sort of all those particularly negative perceptions about your group, and you begin to internalize that. And we know that that actually has health consequences for people when they begin to internalize all those negative messages. And for children, we actually see it early on in terms of how they see themselves and how they go through life early on when they see that people who look like them or from their racial culture groups are not treated the same way. And so this RISE framework really integrates a lot of different frameworks from the bioecological framework. It also integrates, the life course theory, right, that Dr. Shelton noted, which is the idea that racism, for example, really we can see that happening over generations, right? For example, when you see lead, when children ingest lead, it actually passes through the bloodstream and actually could have impact on 2 generations down. So we have to recognize that equity has to think about historical issues. So when you have actually harmed people over generations, how do we actually address those historical and also those current issues as well? And then we have to also recognize the intersectionality, right? So in the end, when we think about policies, again, as noted earlier, you can think about it as how does this work for, say, this particular community or this particular group? But we have to think about intersectionality. What does it mean for a Black female versus, say, a Hispanic female, a Latina, right? Or versus a male, right? Or somebody who may have a different gender identity. We have to be able to think about policies and how they influence health outcomes for those who have different identities, especially when they're marginalized identities. And then finally, I do hope that as we talk about inequities and the solutions for public health policies, I want us to sort of, make sure that we also think about the cultural assets that people bring, right? From the community level and the family and child level, right? Think about sort of aspirational capital, the idea that you continue to hope for the best and still continue to move forward, even when you're being told that you are not worthy, right? So we have to think about some of these assets in our policy making and realize that people don't just sit at home and want to be poor and collect welfare checks, as was often said, but that people are really trying to find different ways to navigate a system and our programs and services that were not built for them. So how do we think about cultural assets and community assets as we think about issues of inequities? That people have to be fully humanized, right? If you see me, I grew up in poverty. And again, think about it, right? When you grew up in poverty, you think you're just poor, but there's so much to that family and that community, right? The kind of family members that they have, the kind of ways they persevere, their spiritual capital. We have to think about the fullness of people as opposed to some of those sort of challenging circumstances that we have placed them in. So then if after hearing all of that, what does that mean for what does it mean for public health policy? Next slide, please. So I would say really in the end of it, if we're thinking about sort of issues of public health and really in the end of it, it's all about well-being, right? Public health is really, it's all about thinking about people, children, families, and communities from a really holistic lens. And so I think of this from what I call the 3 Ps of child and family well-being, right? And so the 3 Ps really are around the issue of protection, right? So how are we ensuring that children, families, and others are free from harm and trauma and adversity, right? That is the first and foremost of a human condition, is that are we physically, psychologically, and emotionally safe, right? Think about yourself. Protection, how are we protecting families and communities and those sort of things? The second is not that I'm sort of physically, maybe and emotionally sort of safe. How am I promoting the best, right? So how am I promoting your health, whether it's physical health, emotional health, psychological health? How am I promoting your health? But also, how am I addressing wealth, right? In the end of it, public health is only possible if we address basic resources of both health, but also wealth, right? When you are economically vulnerable, it is really hard to have the best mental wellness. And so we think about issues of wealth and asset generation. And then how we think about educational excellence. For me, who studies young children and the settings that they're likely to be in, how do we make sure that they're in healthy spaces, right? Whether it's physically healthy and safe spaces, but also emotionally, culturally, and spiritually healthy spaces. How are we promoting their educational excellence and well-being? And then finally, preservation. To me, public health and any policy should often think about How do we preserve the best of who people are, the best of their community conditions? And if we're not doing that, are we really doing what's best, right? So for example, you're gonna say, I'm gonna improve your health by moving into a different community. Is that helpful to me if my whole entire ecosystem, my whole entire familiar system, my whole network is in a particular community I live in? If you move me somewhere else, is that preserving the best of who I am? So how are we preserving family, culture, language, community, and even identity? Because we know the more that we think about children of color, Black children especially, whose own identity are often being challenged in social media, in news media, in the community on many levels. How do we make sure that we're preserving their sense of self and their sense of well-being? And so what does that mean in terms of policies that we can think about? Next slide, please. So in November of 2021, I partnered with the National Black Child Development Institute, one of the oldest civil rights organization that focuses on young children, and we really, crafted the Black Child National Agenda that really looked through our evidence so far on what could begin to it's almost like a blueprint, what could begin to place the health and wealth and well-being of Black children on a path towards humanity in many ways. And so we sort of look through all of what are the potential policies that we see actually being enacted either nationally or even on the local level. And in the report, I'm happy to share the report, we really articulate what are the big policies that we can get started with that can really ensure that America delivers on its promise, particularly to Black people and Black children specifically. And I'll go through them briefly in the next slide. And I go through it really through the 3-piece framework. The next slide, please. And so and you can click for me once. And so if you look at it from a 3-piece angle, so protection. So the policy that we think about for protection, right? We're trying to protect children from harm, both physical, psychological, material hardships. We think about child tax credit income supports. We have seen that for Black families and Latino families, that even that 6 months of child tax credit really helped at least reduce some stressors. It was very temporary, but we found that it was actually disproportionately beneficial for their material hardships, for their economic stability. We also know that addressing harsh and unfair discipline, we don't think of this as health, but this is a health issue. When young children are being, in essence, excluded or really removed from early intervention or early child programs, they are actually in danger of other things. So how do we address unfair and disproportional or discipline that seems to impact on Black children, Native children, and children with disabilities, right? And then finally, ensure equity in early intervention and special education. Again, I pointed out that Black children are likely to be born preterm and low birth weight. That predisposes them actually to behavioral and cognitive challenges. If they're less likely to get identified, get the right services and access, and then the better outcomes, this is creating sort of cyclical issues over time, right? Whether in early intervention, eventually special education. And if it's never addressed, that has actually lifelong consequences. Next click for me, please, Shane. And then promotion policies, you can click one more time. We know we need to think through the experiences that people have, right? So we know that we have racial disparities in wages. We know, for example, that Black women earn about 72 cents to the dollar of a white woman. That has actually familial and community implications. So how do we promote, obviously, address racial disparities in wages and also career advancement and leadership opportunities? How do we even address things like Family and Medical Leave Act? Because we know that's actually beneficial, not just for helping others, but also beneficial for health outcomes on many levels, right? For families to be able to bond with their child, whether adopted child or child that they just had. And of course, expanding health insurance, right? How do you do public health policy without talking about health insurance? And again, I should also piggyback off of Dr. Shelton. Having health insurance does not guarantee good health. It does not guarantee good health, quality healthcare, right? But it's a beginning. And so how do we ensure that that happens? And then of course, for us who think about early childhood, we think about how do we expand universal access to early care education. For many Black families who work really as soon as children are born, being able to access high quality programming is critically important. But that means we also have to pay the workforce because we're right now having a detrimental sort of issue around early care education. And then finally, preservation policies. Can you click the next twice for me, please? Preservation policies. So in the end of it, we have to invest. If we think about public health, right, it's really a community-wide event that needs to happen. It's not just about the children. It's not just about the families, it's about the community. So how do we invest fully? And we've done a lot of disinvestment, particularly from Black communities and Black organizations. But how do we invest in Black-owned and Black-led businesses, organizations, and institutions? That is critically important to public health because they're able to speak to the cultural history, the roots, the needs of those community members. And that means that we have to also ensure that our workforce are well trained to address the specific, unique sort of experiences of that community. If we don't have the right training and the right sort of curriculum and practices in place, we can have the best policies, but how it's being implemented may not actually meet the needs of the community. And finally, our last one around preservation, around reparations. And I want to just flag that reparations, not just about sort of economic transfer or even economic payment or down payment, really, but it's really about, you know, in the end of it, for us to move forward and have a healthy, thriving society, we have to actually recognize that we have harmed people, and repairing damages done in the past and the present is a way to move forward. And to me, part of public health is making sure that we are actually saying we have harmed you and we're going to try to fix it as best as we can. And then last slide, please, the take home message that I have. I just want to sort of leave you all with the idea that, next slide. So I want to leave you with the idea, really, you know, as I pass it on, is that, you know, we have to examine inequities, but really not just race, right, but also racism, but really racism, and obviously, arguably, sexism, classism, right? All the isms have to be addressed and really take an intersectionality lens. And I really urge us, as we think about just public health policies, that we think about specifically, how is this protecting families and babies from harm and trauma and adversities? How is it promoting their health, their wealth and educational excellence and access? And really, most importantly, how is it preserving their family units, cultural heritage, language, and positive racial identity? We did a brief really around interracial policymaking with the 3 Ps, and I'm happy to put that link later on the chat that really shows the kind of policies that can meet some of these 3 Ps. And then finally, I encourage you to look at the Black Charter agenda, whether or not you work in a community of Black people or other people of color or even white people, because in the end of it, I will argue that any of the policies that I have flagged, whether it's the child tax credit, the family medical leave, or even culturally responsive practices, the more that we do those kind of policies, we know that everybody's going to benefit. But it also means that we're going to really address the historical legacies of racism and the contemporary inequities that still exist with us today. Last slide. And so with that, I say thank you all, and I look forward to the questions later on. Feel free to follow me at LinkedIn or Twitter at Ioma Iruka, but also feel free to go to the website. Can you go to the next slide, please, Shane? And feel free to go to our website. I thought I had my website, but I'll put the website in there as well at the equity.coalition.fpg.usc.edu. Thank you so much. I look forward to the conversation later on.
All right. Thank you, Dr. Iruka. Our final speaker today is Dr. Vicki Johnson-Lawrence. Dr. Johnson-Lawrence is a senior research public health analyst at RTI International and formerly an assistant professor in the Department of Public Health and Health Sciences at the University of Michigan. Dr. Johnson-Lawrence is a social epidemiologist that uses community-based approaches to address determinants and prevention practices to promote health equity. Dr. Johnson-Lawrence.
Good afternoon, everyone. I think this is a fantastic opportunity for me to share with you some of the ways that I have been amplifying the voices of doing community participatory work. And as we go into this presentation, Shane, can we move to the, thank you, sir. As we go into this presentation, what I'm really advocating for or suggesting here is that communication, collaboration, and partnership can drive prevention science and make it more effective, can help that reach and adoption be that much stronger when we're in communities where there are high needs, when we're in communities where we are seeing high levels of inequity, and in places where we know health is a struggle to address. Next slide, please. When I think about prevention science, and particularly in thinking about health equity, I'm thinking about the ways that we are able to take the science, the evidence-based work that we've been doing, the science that we have already learned from decades past, and put it with the information that we know now, the setting and contextual information that we have at our fingertips now to serve in the communities that are facing their own particular challenges right now. And in doing that work, it means I'm thinking about what the contextual factors are that will keep us from having an equitable application of prevention practices. Equitable prevention practices are essential for improving our communities that are experiencing high levels of inequity, health, and otherwise. When we have equitable prevention practices in place, we know that those communities, those persons who are receiving or on the beneficial end of those prevention-based practices, they are experiencing lower treatment costs, especially if those equity-based factors account for the context or the barriers that might be in the way for receiving effective care. We know that when we address or implement equitable prevention practices, there is an increase in access to social opportunities that might not have stood or might not have been as available because of health-related barriers. We also know that in order to see equitable prevention practices take hold, that there has to be upstream investment and partnership and collaboration with members of the communities that are in need of service. It's going to be a requirement. It will always be necessary to make sure those voices are contributing to the decisions being made about where funds will go and how resources will be allocated to ensure the contextual factors or barriers are being addressed. Next slide, please. Partnerships effectively support prevention and health equity. And I am a proponent for participatory methods when we use them as a strategy to make sure the evidence that we are collecting or the data that we are collecting is reflective of the various perspectives that need to be accounted for. Participatory methods allow us to get perspectives from members of different backgrounds in different spaces with different needs into the conversation and ensure that our assessment of whatever the problem is when it comes to health outcomes, that our assessments are accounting for the needs of those particular populations. So on the slide, the article on the left says community-based participatory research enhances participation of racial ethnic minorities in clinical trials. And it's based on a 10-year systematic review. Ultimately, they saw that more than 85% of the studies that employed community participatory methods saw statistically positive outcomes. And it means that we are accounting, we are listening to the otherwise left out, perhaps previous oversights. We are listening now to those concerns of members in the communities that might have been left behind before. The image on the right from the Nevada Minority Health and Equity Coalition points to the benefits of CBPR with a few bulleted points, but ultimately CBPR does a great deal to rebalance the power in how decisions are made, ensuring that the people who are researched also have power and it's balanced with those who are doing the research. Next slide, please. From here, what I want to do is look at a few examples of ways in which partnership and collaboration between community members or community groups has been beneficial to policy-related outcomes or policy-related changes. And when I think of policy, when I address policy for the remainder of the conversation, I'm thinking of policies that have operated at federal levels, operated in times of crisis, but also operating at local and state levels. All those spaces in which community voices have been critical for moving forward health promotion related policies, moving forward and elevating equity and health outcomes, and especially so for communities that may have been underserved, marginalized, or minoritized for various reasons from based in the past. Next slide, please. In thinking about funding, our federal agencies here in the United States have paid attention, have drawn attention to the need to address health equity. And in some of these partnerships or in some of these funding initiatives that have come forward over the last several years, it's not a new idea to talk about health equity. So on the left, I'm pointing to a relatively new initiative at National Institutes of Health, the Community Partnerships to Advance Science for Society, the COMPASS program, which is currently pulling for the community voices to lead health equity health equity-based initiatives and ensure that we are using evidence through the eyes of community partners to drive health equity at a large scale. On the right is pointing to work from the Agency for Healthcare Research and Quality. And again, not necessarily a new program, but it does demonstrate that we do have federal agencies. There is attention at the federal level, federal funding being put toward ensuring that participatory approaches are in place to help our funding decisions be driven by voices from members of the communities that are affected by various types of health inequities and disparities. Next slide, please. Here it's referencing funded work through CDC and in particular prevention research centers. Here, the first image is about the Diabetes Research, Education, and Action for Minorities program, the DREAM program. The center program, or the center image references the Faith, Activity, and Nutrition program. And the program on the right references the REACH program. All of these are CDC-supported initiatives. And what they have done in these spaces is created space for community members to work alongside researchers and support researchers in understanding what community needs might be have been standing for years, and may be to come, or serve as maybe barriers, sometimes facilitators of using effective evidence-based practices. So in the DREAM program, thinking carefully about how diabetes has a differential impact on minorities, thinking about how we can ensure that minorities and communities otherwise minoritized have access to the resources that they need, the education that they need to care for themselves when managing managing diabetes. With the Faith, Activity, and Nutrition program, I can specifically say that these types of projects, understanding from the faith perspective how we can better our health from a community setting, has been critical for building out community participatory approaches around the country. I can specifically say from some of my own work, we've built faith-based initiatives to promote nutrition and physical activity following some of the work related to the FAN initiative. And thinking about REACH, I've done work in the Michigan communities, working closely with REACH, one particular REACH community. And because of the work between the community partners and the researchers leading one of the Michigan-based projects, those community partners have gone on to do additional projects with other researchers that are advancing health equity in other ways. In other words, when we see effective prevention initiatives, it has been beneficial long beyond just the project that might have started that work, and propelled community partners to advocate for health equity and health improvement in other spaces and in other ways. I've seen a number of community partners, because they have been engaged in these ways, take on other initiatives, take on other health projects to ensure that their communities are benefiting from the science that so many researchers around the country and globally have invested to address. Next slide, please. Another space in which prevention science and health equity have been critical is with crisis management. Next slide, please. In relation to COVID-19, multiple articles, multiple studies, and multiple researchers and research centers throughout the US have documented disparities of various types related to COVID-19. In some cases, it's related to testing. In some cases, it's related to outcomes. In other cases, it's related to trust or distrust because of previous community issues. The article here in Preventing Chronic Disease notes the benefits of using community-based participatory research to reduce COVID-19 disparities in a particular community in Arkansas, or two particular communities in Arkansas. The use of CBPR in this setting was significant, not only because CBPR methods have been shown to be effective for improving communication and having communities adopt practices that might have otherwise been concerning or had a number of barriers to access, but it emphasizes that CBPR, participatory methods, have a number of facets. So there is a communication component. There is a space where we need to ensure that community partners have a voice. There is a need to ensure that community partners are included in decision-making from beginning to end, rather just as an afterthought, consistent with what Dr. Shelton said earlier. It is critical to have partnership from beginning to end, from the idea stage to the implementation stage and through to the evaluation stage, because when our CBPR projects, or really when any of the implementation efforts for our evidence-based studies or evidence-based strategies are in place, if we have not taken the time to get a clear accounting of the various contextual factors that may or may not be contributing to how well our evidence-based practice is adopted, then we will incorrectly conclude that a particular strategy does not work, or that a particular community just won't change, or that a particular community cannot be helped. And those are all incorrect conclusions. We have to use partnered approaches when we are trying to ensure that we are properly applying our policies, properly applying our programs, and listen when they tell us why they might not be working. Next slide, please. Another way in which crisis management has shown us the need for participatory approaches and collaboration is in looking at our response to major community stressors. So for example, the Agency for Toxic Substances and Disease Registry made it a point to reach out to communities around the country and ensure that they collected voices, perspectives about how we respond to community stressors. I did a great amount of work in Flint, Michigan during my response efforts to the Flint water crisis. And because of that work, it became quite obvious that even if we're not managing a natural disaster, even if we're not managing something that might seem like it should be acute, so those slow rolling sorts of community stressors, it's necessary to take a systematic approach and ensure that our community partners are being heard the entire process through. There were other water stressors in the state of Michigan at the same time. The ATSDR initiative was responding specifically to PFAS in drinking water, but ultimately it was a conversation about the psychological and social stress that comes along with experiencing a physical health stressor at the community level. So when we are thinking about partnership, there has to be an acknowledgement that ignoring whatever our community partners think is critical will lead to a new barrier. It will lead to mistrust. It will lead to a gap in uptake and trust implementation of whatever evidence-based strategy we are trying to bring forward. But when we extend or create space that allows those partners to contribute to the conversation and be heard and be engaged, and importantly, not be dismissed, when we make sure that space is available and we use the feedback that we collect to make new decisions, we have a much better strategy to respond during crisis conditions. Next slide, please. I'll only further emphasize this point with this particular slide about the Substance Abuse and Mental Health Services Administration funded Resiliency in Communities After Stress and Trauma grant program. This program was specifically supporting communities that were facing or that had recently faced civil unrest and managing how we address and rebuild resiliency when those communities have gone through something significant. The image on the right reflects the RECAST grantee in Baltimore. Not only did the RECAST program in Baltimore ensure that youth were engaged, but they used the heavily community participatory approach, once again, to partner with or to foster partnerships between local public representation, local government representation, and local community leaders to ensure that community voices were being heard when decisions were being made about how funds would support the community in response to the various issues they were facing. And by various issues, there have been a number of concerns about violence, about housing, about other issues that had long plagued the community that RECAST was supporting a response for. Next slide, please. In these last few slides, I will point to spaces where community participatory approaches were significant. And I can speak to it, especially on a local level, but the work has been happening around the country. Next slide, please. Communities around the country have focused on the ways that we can bring health equity into the various spaces where decisions are made. This is one such example. Health equity in all policies, health in all policies, has shown up with support from multiple organizations, including APHA, as in up on the right-hand side of the slide, but it's shown up in multiple communities because we recognize all decisions, all policies can easily be made without an acknowledgement to the various forms of health that a person holds dear. While we might have some very obvious ways that we think about health, or we might have some very obvious ways that we might conceptualize improving health and well-being, sometimes those formulations don't apply to other communities, or sometimes they're just not obvious in those other communities. And the health equity in all policies frame suggests that we should think about it more intentionally, regardless of the policy. So even when we are thinking about transportation policy, and perhaps it's more obvious when we're thinking about climate change per se, but if we're thinking about transportation policies, there's certainly an aspect of health and equity to be included there. When we are thinking about where a park is located, when we're thinking about any of the spaces or decisions that will affect how people make decisions, how people move around, how people live their lives on a daily basis, there is most certainly a space to consider health and, importantly, health equity. Next slide, please. Similarly, there are initiatives like Tobacco 21. Tobacco 21, just for clarity, Tobacco 21 raises the age for purchasing tobacco from 18 to 21. There have been communities around the country. There's a nice site, tobacco21.org, that has shown the various ways that we might, or various communities that have already taken the efforts or taken steps to raise the age for purchasing tobacco from 18 to 21. When thinking about health equity, or perhaps thinking about health inequity, there are essential reasons to do policies like these that drives community engagement and not solely watch this play out at a policy or in a policy space. So for example, in African-American communities, there's much more marketing, much more advertisement in communities of color for menthol-based tobacco, because menthol masks the flavor and makes it more appealing to younger age groups. When there are policies in place that reduce the likelihood or reduce the accessibility of flavored tobacco products, we see that those communities that had more marketing for those purposes are able to lower their rates of health conditions, health problems related to smoking or related to tobacco use. My point is ultimately that communities know the problems, see the problems that are around them, and they can tell you what some of the issues are or what contributes to those problems being persistent. Tobacco 21 is one such demonstration of community members coming forward, noting that this is a problem, pushing for the local governance to address the issue with policy. Similar communities have done it around the country. Next slide, please. Ultimately, prevention science is stronger when impacted community members are drivers of the interventions through collaboration and partnership. And again, this means from the beginning, at the idea generation stage, through the end, meaning implementation, evaluation, and sustainability. It's necessary for community partners to have space and voice in these conversations because they can help us identify, and by us, I mean researchers, but more broadly, those implementing policies and evidence-based strategies. Community partners can help foresee what concerns or what barriers might be in the way and identify facilitators to move forward. Community members should really be part of all of our conversations when we're making health-related policy, when we're making really any policy, and we can turn to community partners to help us ensure we understand the health equity and inequity that might be related or resolved with the policy approach that we suggest. Thank you.
Thank you, Dr. Johnson Lawrence. So now I'm going to ask all the panelists if they could come off or come back on video. We've got a few questions here and 15 minutes to get through them. So we'll try to get through as many as we can. But if you still have questions, please do submit them in the Q&A box, and we'll try to get back to you at a later time. So the first one here, the person notes that champions at multiple levels that advocate for implementation of evidence-based policies typically enhance the implementation, fidelity, and uptake. So are there efforts underway to promote training and incentives to strengthen the effectiveness of such champions? And this would be for any of our panelists.
I think I responded, so I'm happy to start. Yes, this is an excellent point, and I'm happy to share an article that's kind of looked at lessons learned in terms of identifying and building champions in these settings. There's a lot of work in implementation science on identifying those. I think one of our challenges is a lot of my work is in sustainability, and sometimes we invest too much in one person. And I think it's really important that we're thinking about almost teams of champions and not just champions in one settings. We know that the partnership piece is so important. And I think sometimes we invest too much in kind of those one or two champions, and then there's real gaps, you know, if those people leave or if their priorities shift. So I think we need to be thinking about teams of champions that can support this. I think one of the challenges as well with this is a lot of times this is kind of something extra. You know, this is not a billable service, this is not reimbursable. So how are we using our resources also to support this and identify who should those champions be? How are they aligned or not with the communities and settings and populations we're trying to serve? So those are some of my initial thoughts. And again, happy to share that article if you want to reach out to me.
And I'll just expand just briefly on what Rachel said, especially when we think about champions. There's been this movement, and I think it's great to make sure, for example, in my space of early childhood, to include families and especially those from historically and underrepresented groups. That's really important, but it's to be careful that you're not putting all of the fix on their shoulders, right? So you want them in the room, you want them to be part of the solution, but you don't want to make the burden theirs because it's likely that they were not part of creating and maintaining it. And so it's how to balance including, especially those from historically marginalized communities, in the whole entire plan, but not placing the burden on them because eventually we're going to place the blame on them when things don't go right, right? So I think it's being very careful with sort of some of those ideas.
So I'll say that there are certainly youth-related programs in which I'm connected to a few where they are intentionally working with youth to think about their boundaries. So how much can you really do, and understand when it's time to partner, understand when you can be the champion, understand what championing looks like with different levels of resource. So yes, we would love for more training resources to be developed. But we also know it's quite the lift to train others to advocate when they have to face a limited number of resources.
And we have a related follow-up question. Are there efforts to assess and ensure that champions or community partners are led by people who truly reflect the community?
Not always. I don't think we can assume that. And to both, you know, I think this was reflected in all of our presentations that we have to start with that, right? This will have, you know, that will kind of have potentially negative or harmful effects if the champions do not reflect the communities that we're seeking to serve. So again, and, you know, with the example that I brought up where, you know, there was actually distrust of the guidelines because the data didn't represent them. And also the source from which the data was coming was also not trusted, right? So there are multiple implications in terms of how that impacts both uptake and inequities. So I think that's really critical.
I would just flag that, you know, a lot of times, right, especially with sort of minority-led sort of organizations, institutions, a lot of them have been there, right? They've been working they've been doing this work, whether or not they had a billboard, a website or whatever, So I would say that it's important that those of us in privileged and power positions, whether it's policy making, whether it's funders, et cetera, that we go and look, right? If you actually go to a community, for example, there's always elders. A lot of those elders they've been doing work of advocacy, community building, capacity building, right? They may not have called it these terms that we use, but they are there and they've been doing the work, mocha moms. There's a whole lot of different, and that's why I say the cultural wealth of communities and people, you build a lot of different sort of things, right? Because you understand that the regular infrastructure or system will not think of you, will not include you at the table. If they do, it's temporary. So you actually begin to create ad hoc, culturally grounded sort of spaces. So I would say that there's a lot of examples where this exists. They just don't have the money, but they're not doing it for the money. They're doing it for their people. And so I think it's important to look at a lot of organizations, indigenous and tribal communities, in sort of Black and brown communities. You'll see a lot of these examples. Home-based providers, for example, they don't get paid, but they are doing a lot of advocacy of families, of children, of other peers. So there's a lot of that. We just have to see them. They may not have a website or name, but they are actually there.
And another question that's also related. So how do we address the historical distrust and skepticism between communities of color and researchers or research intentions? So in a lot of instances, the historical mistreatment and exclusion of participants of color in research studies poses a barrier in overall participation that would impact research and public policy.
I'm looking at Dr. Johnson, not to put you in the spot. Dr. Johnson Lawrence, I feel like that was your question, but I can answer it too.
So this comes down to relationship building, in my opinion. When we refuse to take the time that is required to build a relationship, we just see this mistreatment to ultimately fester. So in addressing it, some of it is being head on. I actually think one of the strategies that we used in Flint was to acknowledge and debunk when there was a myth, but also acknowledge when there was truth to the issue. It required us taking the time to identify community members who were trusted, understand what they believed about the concern, listen to them when they bring these concerns forward, and then provide them with resources to either clarify where the misunderstandings are, or in some cases decide that it is really time to start anew. In other words, it might be time to change who's leading the project. It might be time to take a new approach. It might be time to step back. I don't know that on the whole, we've been so great at being comfortable with the stepping back. But those who tend to hold power in these relationships or in these situations, if the goal is really about addressing that health inequity issue, then we have to be willing to step back. But if the goal, implicit goal, is to hold on to power, then we might continue to see the same sorts of problems that we were seeing before.
If I could just add, Dr. Johnson Lawrence, yes, I would say that as a researcher myself, and who swims in this community, right, especially as a Black person also, right, is that researchers, we have to come to the moment. This is a moment. We have to recognize that we have to do our own internal work. We have to understand that some of our theoretical frameworks, our question, even our measures, that the ways that we have approached communities, particularly I will argue Black communities, indigenous communities, the way we have actually set up questions, the way we see groups of people, it's pathologizing. It's also harmful, it's detrimental, and it really sucks and hurts. I hate to use those terms, right? We have to, so for me, I think that researchers are, we think we're doing this objective thing. We literally are not. We're bringing all of our baggage into this space, and we also don't recognize the full harm that we have done and continue to do even till today. So I will argue that part of that, I completely agree with Dr. Johnson Lawrence, we have to build relationships, but we have to actually look at ourselves and our methodology and also realize that we have power. That means that we have power of the science, we have power of the translation, we have power of the person in many instances. They will listen to somebody with a PhD, an MDD, or whatever before they listen to community members. We have to understand our power has helped to create the inequities that we have. And if we don't actually really address it very clearly and succinctly and clearly, is going to maintain even if we have good intentions. So I actually feel like we need to do some work over here, and the community is going to continue doing their work. And our job should be to exactly step back and in many ways really, really see the community for what it fully is, see the harm we have done, actually make some apologies, aka reparations in some instances, and then figure out how do we do this work, I think that in the community participatory way, but really in a real way that acknowledges our biases, our faults, and also have a level of humility in that work.
I agree. And to everything that was just said, to all those points. And I think we also have to acknowledge that it's going to take time to build trust and trustworthiness of our institutions and of us as researchers. This has been going on for hundreds of years, and it's going to take time. It's not going to happen overnight, but it requires us to also be accountable internally as researchers, but at our institutions. How can we advocate and use our power for change at our institutions to be more accountable and how we're investing resources, the questions we're asking? And it really requires, I think, a shift in our funding structures. We don't have, there were some great examples that Dr. Johnson Lawrence highlighted about Compass and other community-led initiatives, but we don't have a lot of programs that really support those sustained relationships and those sustained partnerships that we know are critical. If we're just taking action in the context of research grants, that does not build our trust and trustworthiness to communities. So we have to shift and transform that whole model of how we engage and interact with communities to build that trust and to demonstrate that over time.
Thank you. I think this will probably be our last question. A little bit of a different topic. The question is about positive childhood experiences. So how do we bring the protective qualities of positive childhood experiences to individuals and families without PCs being seen as pandering and taking care of the quote unquote frills and not the quote unquote foundations?
I'll just briefly answer. I answer a little bit, but I would say that at the end of it, right? I always go back to we have to humanize people, right? So if I look at myself, I have many strengths in many areas that need strengthening, right? So we need to be able to tell the full entire story and humanize people. And I think that the positive child experiences are also important to bring. We talk about adverse experiences, but you're right. We cannot use sort of the positive child experiences to cover up the systemic inequities and all the adversity. So we need to be able to, as I say, walk and chew gum, right? We have to be able to talk about there's all these great assets you have, family, community, child, but there's all these other larger things also happening that we must also attend to that really tells the full story, right? It's like a quilt. We have to tell a full story. We can see the different threads, the different patterns, but we have to tell the full story. And to me, that's what's really important with that kind of question, that we have to tell the full story to be able to really, I think, have the best impact.
All right. We might have time for one more then. So, and it's about disaggregating data. So in Minnesota, there's a large population from West Africa. And so when looking at interpersonal systemic racism and interpersonal racism, particularly around youth positive identity and development, have those data been disaggregated within the broader minority categories?
So I'll briefly answer and say not specifically, right? There has been some work done really, like the Migration Policy Institute has done some work, not so recent, really looking at sort of the diversity of Black people from both Caribbeans here, descendants of enslaved people, African, etc. There has been some, but I think the question you're asking has not fully been done, and that work is actually happening really soon. So I say stay tuned, because there is more work to really unpack sort of that issue of the diversity of Black people and how they're experiencing structural racism, interpersonal racism, and other kinds of forms of adversities as well.
All right. And how can people who are getting really interested in this, maybe a little bit more on the periphery, how can they get involved with this work?
I would just briefly say, I'll put my website in the chat. And I say there's so many resources. I'm happy to connect people. Feel free to engage, connect. There's so many opportunities, but I'm happy to sort of share the website where we have a lot happening, but also we do a lot of work with different community partners, organizations, et cetera. But I imagine that both Rachel and Vicki have things to add.
So when the materials go up, I will be sure to include a few supplemental links, hopefully to respond to a couple of the additional questions in the link. And yes, I'm sure that there are ways to get involved. Most often I see this, the best ways to get involved tend to be at the local levels, because then when there are nice sized local collectives, you have more power. Your voice tends to be louder. And in my space or in my history, that really has come down to engaging with a cause that I stand behind at a local space, or identifying a community that is trying to address a problem that I think I can bring some support and expertise to, and sharing it there. But also know that it means listening first, talking way later, and hearing what the needs are in the space that you decide to join.
Well, thank you all so much. I also want to highlight NPSC's website that has a lot of resources. We will post the recording after this, along with additional resources that people have put in the chat and resources from our presenters. So thank you all for participating. Thank everyone for watching, and have a great day. Bye.
Happy holidays. Thank you.